Welcome to the Mentors and Moguls Podcast, your source for the inside scoop from some of the world's most accomplished business leaders, athletes, and creatives on how they've achieved success. I'm Heather Stone, a serial entrepreneur with a passion for helping others to overcome challenges and discover their untapped potential. Join me and our guest as we teach you how to break through those barriers on the way to crushing your goals. In each episode, I dive into a new topic with an inspiring mentor to find out exactly how they overcame obstacles, slayed self-doubt, and achieved their goals. Today's expert mentoring session is about to start, so grab your pen and let's dive in. I'm very happy to have a very distinguished guest. We've got Dr. Ashish Jha today. He's the director of Harvard Global Health Institute. He has become quite the expert, as you've seen in media all over the world, on the coronavirus. And I welcome you today, and I look forward to asking you a lot of questions that's on people's minds today. Welcome.
Thank you so much for having me, and I hope I can be helpful.
Yes, I'm sure you can. All right. So I'm going to start right at the top of this. I was looking at the stats this morning, and sadly, the U.S. is leading with the number of deaths that's reached 154,000. And I hear predictions that we could be at 200,000 by November 1st. What do you say to that?
Yeah, our own kind of internal forecasting has us hitting, unfortunately, 200,000, probably earlier than that, maybe even by the end of September. But whatever the true number is, it's astronomical. It's unlike any other country in the world. We have the worst performance on this pandemic. We have mismanaged this pandemic worse than arguably any other country in the world, though you could make the case that Brazil has mismanaged it as badly as we have. But the bottom line is when you're competing to be the worst in the world, you're not in a place where you want to be. So it's a very sad and unfortunate situation, and of course, completely unnecessary, given how much resources we have, what incredible scientific talent we have. I think most of the deaths we have had so far were preventable, and I think most of the deaths that are forecasted are preventable.
Interesting. So I read this morning that there's 18,000 people in the western province, I think it's of the Jiangxin, in China, if I said that right, that they've got like a second wave coming up in China and in Australia. Do you think there's a mutated strain? Is this the original strain that's coming up with this second wave?
Yeah, I don't think there is any, this is a mutated strain. I think the way to think about this is, we're in the middle of a global pandemic. We are going to see little outbreaks and hotspots pop up here and there. It is not surprising, even in countries that have done an extraordinarily good job of managing this virus, like South Korea. They've had, because they've done such a good job, they've had nightclubs open. Well, then it turned out that somebody who was infected went to 5 different nightclubs in one night and got a couple hundred people infected. Mm-hmm. So these kinds of things will happen. It's just right now there isn't any other country, because again, with the maybe exception of Brazil, that's seeing these kind of massive outbreaks across large parts of the country the way we are in our nation. But I see those little outbreaks in Australia, China, even 18,000 as like part of what we should be expecting in this pandemic.
What do you attribute our poor performance in the United States to at this point?
It's very confusing in some ways because we had, I shouldn't say we have anymore, but we had the world's greatest public health agency in the CDC. The world's, all of the countries modeled their public health response after the CDC. We have underinvested in public health for a long time, so that's clearly part of the issue. A large part of the issue has been the sort of, it's kind of almost hard to talk about, like the shocking level of denial of basic math and biology. That there are still large numbers of people who question the fundamentals of how biology works, how viruses work. Mm-hmm. They continue to question the basic science behind this virus. It's almost like, we just have a large chunk of people who sort of believe that the earth is flat. And it's very hard to counter a complicated problem like a pandemic when you have this much misinformation. And that misinformation is largely spread through social media, largely through Facebook, and has really become a major source. So it shows up in things like, we're the only major country really debating whether masks are dangerous or not. Masks are not dangerous. Like, that's not a debate that people in the UK are having. Some people don't want to wear masks, but the kinds of stuff that we see debated in the United States, no other major country is really having a debate about hydroxychloroquine the way we are. No other country has these big debates about whether testing is good or bad. Everybody thinks testing is useful. So it's just, we have very awkward debates. Again, the kind of like, is the planet round or is it flat? Or you know, is the Earth round? And that's, it distracts us. And so we end up having these very, very large outbreaks. We've been very slow to respond to them. A ton of misinformation, not just from social media, but also coming out of our political leaders. We had a congressman from Texas who just got diagnosed, and his first response was that he thinks he was diagnosed because he got infected because he was wearing a mask. Mm-hmm. Like, I don't know, like there's an element of, this is really serious business. We're in a pandemic and we're having very unusual debates that no other major country is having.
Well, you bring up a good point. So let's go down the road of remdesivir and hydroxychloroquine a little bit. And none of this is politically fueled with my questions or your responses.
That's fine. Yeah.
Basically, I've been doing some research on the two. Remdesivir. So it's out there. It's being used. It's not really approved yet, I think, as the drug to combat coronavirus, but it's being used in some of the more severe cases, correct?
It is approved. It has emergency use authorization from the FDA.
Okay.
And it's basically because there's one high quality randomized controlled trial that showed that it dramatically improved recovery, 35%, but that's pretty substantial.
Right.
Recovered. And then there was some suggestion that it lowered mortality, but it didn't quite reach statistical significance. So we don't know for sure that it lowers mortality, but definitely seems to help improve recovery.
Okay. Do you have any thoughts about the cost? You know, whether someone's on a government program, it's a lower cost versus if someone has private insurance, it's a much higher cost. The $3,200 compared to $2,400 for the drug.
Yeah, it is an expensive drug. The question that's been debated is it too expensive? Should it be cheaper? In general, my feeling is for a disease that can be as severe as this, for hospitalized patients, a therapy that can potentially lower mortality, $2,000 to $3,000 is pretty cheap compared to a lot of other therapies we use that have much less impact. So kind of from that objective point of view, it's not a particularly atrociously expensive drug, but it is a good amount of money. And to me, my general feeling on this has been that we should absolutely make sure that individuals don't face that cost. So we don't have, a loved one in the hospital or in the ICU, and you don't have to worry about, do I have to pay for this out of pocket? We should make sure that doesn't happen. But as long as that's not happening, I'm pretty comfortable with those kinds of prices. And mostly have felt like in the middle of a pandemic, given that we're spending trillions of dollars on all sorts of things, making sure that everybody gets access to remdesivir is a pretty high priority. Everybody for whom it could be beneficial.
Right. So let's jump back to Wuhan for a second. Do you think that the latest strain or the current strain is weakening? Is it mutating in any parts of the world?
So it's a really interesting question. Like, what is a strain and what is a mutation? You may say, well, those sound like straightforward issues. But the thing to remember is every time the virus replicates, it has some chance of having some different mutation. Mutations are normal. They're common. And it's actually how we track virus spread over places. So we know, for instance, that New York was largely seeded by cases from Europe. How do we know that? Because we can look at mutations in the virus in New York, and they line up with the mutations from Italy, and they line up. So that's how we track these things. So mutations are very common. The question is, what causes a different strain? When do you say something is a different strain? Mm-hmm. And that's really a functional issue. Like, does it act differently? Is it more infectious? Is it more deadly? I would say so far I have seen no evidence that any of the mutations have led to a strain that is either more deadly or less deadly.
Okay.
Just haven't seen that data. There are some suggestions. Now, there is some suggestion that one of the sets of mutations that then landed the virus in New York from Italy may be a bit more infectious. And this is it's really contested among virologists. And my general feeling is it doesn't really largely change what we do. But if the question is the virus today more deadly or less deadly than the virus of 4 months ago? Largely no, not that I've seen.
Okay. So pregnant women. I have a few in my immediate circle. I know that there are a lot of people that are worried about it. There's not much to study yet because it's so soon after the outbreak. But when pregnant women go to deliver at the hospital, is there anything that they should be concerned about? Do you have any recommendations?
No, hospitals in general are doing a pretty good job. Certainly the hospitals that I've been closely engaged with have been doing a pretty good job of keeping the virus from infecting other people in the hospital. So obviously that would be the thing you'd worry about if you go is, am I going to pick it up? Is my baby going to pick it up? So again, I think most hospitals are doing a pretty good job. But that statement that I just made is not sort of very evidence-based. And what I mean by that is we don't have good data on how much hospital transmission is happening. From the practices I have seen, it seems to me that there's probably not a lot. But one of the things I have been calling for is much more robust data collection on hospital transmission. My suspicion is if your listeners are in hotspots, it's going to be more of a risk if they're in Texas, Florida, Arizona, South Carolina. If they're in New York, New Jersey, Massachusetts, Michigan, it's going to be much less of a risk. Okay. And I would say in general, if you go to the hospital, it's probably not the time to bring 10 family members along. But usually when you deliver a baby, you're probably only bringing one, and all the standard hygiene stuff of washing hands, et cetera, and wearing masks. I don't think there's much else to do. And again, as I said, I think most hospitals are pretty safe right now.
Okay. Global cooperation. Do you feel that all of the medical community is actually cooperating, sharing data, and working towards one common goal to come up with a vaccine, to solve this, to prevent this? What are your thoughts on that?
Yeah, I think among the scientific community, it's been awesome. It's been unbelievable how good the cooperation is. So while our political leaders are fighting and trying to be all nationalistic and say, we're not going to share the data, or we're not going to do this or that with this other country, the scientists are acting totally differently. So there is incredible sharing of data, incredible sharing of knowledge. I have to tell you, when I think about all the things I have learned, I can't even remember half the times. Was that a UK study? Was that a German study? Was that a Swiss study? Was it a Chinese study? Was it an American study? Because great scientists are everywhere. And so the scientific community, I think, continues to very much see this as a global pandemic and respond to it as a global community. Obviously, our political leaders don't always follow that.
Right. True. Well, that's very good to know. So when do you think that we'll be able to come up with a vaccine? I think I read somewhere in the last few days you were talking about a study that's in its second or maybe third phase at Oxford University. Can you speak to that, please?
Yeah, so there are a lot of vaccine candidates out there. So let's just talk about kind of vaccines overall. I'll talk about the Oxford study, and then I'll give you my best guess on timeline, because of course it's all guesses. Okay. There are over 100 vaccine candidates that people have made. This is unbelievable how quickly this has gone. So a typical vaccine takes 5 to 10 years to make. In less than 6 months, we have more than 100 vaccine candidates. About 15 of them are in clinical trials. Phase 3 trial is the main event. That's the big trial where you get to find out, is the vaccine effective? Is the vaccine safe? There's also phase 1 and phase 2. Those are the key thing I tell people is phase 1 and phase 2 is like preparing for the game. And we want to win the game, but how you're doing in your preparations don't really matter. What really matters is how you play the game. Phase 3 is the game itself. So a couple of big vaccine companies are starting phase 3 trials, Moderna, AstraZeneca, and Oxford, a couple of the Chinese companies. And I expect, and now this is expectation, I expect that by November, December, maybe more December than November, but it could be November, we will have data from a couple of these trials. And we will have data about whether the vaccine works. And what I mean by works is, does it prevent infections and does it prevent severe infections? And then we will have data on safety that at 4, 5, 6 months and 30,000, 40,000 people having been, this vaccine been tested on, does it appear to be reasonably safe? We won't have long-term data, obviously, because it will take a long time to get long-term data. But I think by November, December, we'll have pretty good data from a few of these. And then I am optimistic that we'll have more than one vaccine, that we'll have 2 or 3 vaccines, let's say by January or February, that really look like they're working and are pretty safe. And then after that, we'll have to figure out, how do we make sure we have enough doses? Production of these vaccines are already getting going, even now, before we know whether they work or not. And, my best guess, and this is really a guess, but my best guess, maybe my most optimistic guess, is that we'll start getting lots of people vaccinated in February, in March, April. And by like May or so, a large chunk of American people, May or June, will have gotten vaccinated. Could it be much faster than that? Probably not much faster, maybe a month or so. Could it be much slower than that? Absolutely. It could easily be that these vaccines don't work as well, or that there are manufacturing problems. But if I were a betting person, and I'm not, and I don't try to make too tight of predictions, I think next summer will look very different than this one.
Okay. So for those that are hesitant to being the first up for the first vaccine, they want to kind of wait and see how it goes. What would you say to them? What should they look for? What should they think about?
Yeah. So the first set of vaccines are probably going to go to doctors and nurses and other frontline workers, EMS folks, et cetera. And so we'll have a lot more data even coming out of for them. I guess what I would say is, what I think about for myself is I have three questions in my mind. When am I going to feel comfortable taking it? When am I going to feel comfortable having my kids take it? My kids are between the ages of 8 and 15. And then when am I going to feel comfortable with my elderly parents getting it? Those are three questions in my mind. And the short answer is there's no single thing I'm looking for. I'm really looking at the entire set of data. I'm looking for any severe reactions. I'm looking for, did they test it in kids? Did they test it in older people? I'm looking to see what did we find on all of that. My guess, again, is that by early 2021, we'll have a lot of that data. And again, I'm guessing, I'm going to let the science drive this, but my sense is that next spring, my kids will probably get vaccinated and my elderly parents will probably get vaccinated next spring or summer, in line with other people who are eligible. So that, and really it is about looking at the data very carefully and making a decision of whether there's enough to make us comfortable.
Right. So production, do you know of, do you think that everyone is ready? The private drug companies, the producers, do they have a plan in place for when someone finally hits that eureka moment of we've got a great effective vaccine? How can they mass produce it? Because the line's going to be longer than the lines are for testing to receive a vaccination.
Right. Yeah. So what the federal government is doing is through something called Operation Warp Speed is taking 5 vaccines as of now, they may add more, and starting to work on producing tens of millions of doses of each of them already, even before we know whether they work or not, with the idea that if 1 or 2 of them don't work, that's fine. It's wasted money, but it's going to be it's worth making the bet, because if we can shorten the timeline that people have to wait by a few months, that's a big deal. So I've been very supportive of Operation Warp Speed. I think it's one of the few ways in which our federal government has been really quite effective. And so the challenge with Operation Warp Speed with all of this stuff is it's a global pandemic. And so that means India is gearing up to make hundreds of millions of doses. European companies are gearing up to make hundreds of millions of doses. American companies are gearing up. And it's not just a simple issue of can we just make the doses? First of all, you got to have the right equipment, the right manufacturing plants. That much capacity doesn't just naturally sit around. And so you have to and we don't have time to build brand new plants and factories. So we have to figure out what do we repurpose? How effectively can we do it? But then what I think people are underestimating is the very substantial challenges of supply chain. So for instance, you can make vats of the vaccine. You got to fill little vials with the right dosing, the exact amount. We're going to need billions of those vials. And the companies that make those vials are not used to an order for 10 billion extra vials.
Right.
So they have to ramp up their own production. And so the question is, can they ramp up their production? And they have to go to their supply chain. So there's a whole set of challenges. That's just the vials, the syringes. Some of these vaccines are going to need to be refrigerated at very, very cold temperatures. So do we have the capability of doing that? There's a lot of work between now and getting people vaccinated. And my fear is that a lot of political leaders are not appreciating how hard it's going to be, because we're going to be in a global pandemic. It's not about making 100 million doses for Americans. It's about trying to make 4, 5, 6 billion doses for the whole world.
Right. Do you have any thoughts about or any fears that if one country comes up with a vaccination first, they're going to obviously use the majority of the first round for their country and maybe restrict it or maybe charge a high price for everyone else to have access? What does that do to India, which I know is skyrocketing? Obviously Brazil, and of course there's the US. Sadly, we've got a number of cases.
Yeah, so I think that the country that is likely to come up with a vaccine first is China. They're just a little bit ahead and they're cooking along. There's some problems with their vaccines that they're making. And so I don't think, and I don't mean to cast aspersion on all Chinese vaccines, but at least the ones I've seen, I doubt will end up being the ones that we'll want to use 2 years from now. Like, I think they're sort of older technology, but they are moving. And I would not be surprised if by November or so, we start seeing very robust data for the Chinese vaccines, maybe a month or 6 weeks ahead of any American vaccine. And they're also already gearing up on production. And so it will be interesting from a geopolitical point of view to start seeing large numbers of Chinese people get vaccinated with an effective vaccine well before Americans have gotten vaccinated. I think that's an entire possibility. I don't think that China will be able to make enough doses in the first round that they'll be giving it out to folks in other countries. And my guess is it's going to largely be for a domestic market. And I don't think it's going to be many months ahead of everybody else, but my sense is probably a month or two ahead of everybody else.
Are you of the school of thought that the real numbers from China and maybe some other countries aren't really being published all along?
Yeah, absolutely. So I don't know what the China numbers are because it's been hard to get really transparent data from China. And so but I think we have to use our brains about what that could mean, because people say, well, maybe they've had hundreds of millions of cases. No, they haven't had 100, because you can hide some things, but you can't hide 100 million people having gotten infected.
Right.
So I think we have to be realistic about what the Chinese numbers are. So when I say America's got the worst outbreak in numbers, is it possible that China has even more? It's really hard to imagine. It's possible, but I doubt it, because even when China tries to hide things, there's some things that just can't be hidden. Hundreds of thousands of people dying cannot be hidden easily. So I am suspicious. There are other countries like Russia, like Turkey, where the data, it doesn't always make sense to me what's coming out of their official numbers. And so I've been skeptical. I think there's no doubt about it, a lot of countries are not doing nearly enough testing, and that means they're certainly missing a lot of cases. One of the things I try to do when I look at any country's data is I try to look holistically at what do I know about their data collection approach, what are all the different metrics that I'm seeing, hospitalizations, test rates, and try to really paint a more comprehensive picture than just how many people have they identified, because we know you can miss a lot of cases.
Right. So testing, I noticed that you made a comment on Twitter this morning, I believe, about testing. I live in a couple of states. I split my time, but Florida is one of them. And I've had friends that have had woeful experiences with been testing 1, 2, and 3 times and waiting 17, 18 days and never getting a test back, going back, getting a second one, et cetera, et cetera. In the meantime, they try to quarantine. Some have been positive, some not. And the numbers, then they're even getting a positive result when they didn't even take the test, but they registered to take it. So how reliable are the numbers in Florida, and why is that happening, do you think?
So I'm surprised to hear that people who didn't get tested are getting a positive result. That doesn't quite make sense. So first of all, there's some conspiracy theories out there about large-scale fraud among millions of doctors and nurses. I tried to stay away from tinfoil hat conspiracy theory stuff, because there's always conspiracy theories. Right. Could there be mistakes in the middle of a pandemic where things are really bad? There are always possibilities of mistakes. What I do think is happening in Florida and in other hotspot states is, indeed, there's no doubt people are having to wait long periods of time. And that means some people may be going and getting tested more than once, but it doesn't help speed up, potentially probably slowing things down further. But the bottom line is our testing infrastructure in this country is a bit of a mess. And that's what I've been writing about, talking about, speaking about for months, is that in any infectious disease outbreak, the number one principle is you've got to be able to know who's infected and who's not.
Right.
if you can't know who's infected and who's not, you can't control the disease. And the only way to know who's infected and who's not is by testing people. And that's why we need a very robust, widely available, ubiquitous testing so that people know who's infected and who's not. And then what you do with that information is also super important. But until you can figure out who's infected and who's not, you really can't manage a disease outbreak. And our testing infrastructure has been sort of from day one, and for a variety of reasons, which I'm happy to get into, but a variety of reasons, from day one, it has been really mediocre. It has been wholly inadequate for what we need in our country. We've gotten better. Our testing infrastructure today is exactly what America needed around May 1st. And what the federal government is promising now, is promising for late September, early October, that's exactly what we need today. So the problem has been that we're developing testing, but it's sort of 2 to 3 months behind where we need to be. And it's created this vicious cycle because we can't test, we can't isolate, the disease keeps spreading, and we're just constantly playing catch up, and we're losing.
Do you think there's a lot of talk about vaccinations and whatnot? Let's switch a little bit to talk about preventative health. So we know there's people with high risk. So what can people do? I hear taking zinc, elderberry, vitamin C, obviously cutting down on your fat, changing your diet. What do you recommend, if anything?
Yeah, so what we know, again, based on evidence, is that beyond age, chronic comorbidities, diabetes, cardiovascular disease are risk factors. And obesity is a risk factor. So now that's, can people really lose large amount of weight in the next couple of months as a way to prevent severe complications? That I don't know. Right. But being generally healthier, being more physically active, losing weight are all things that are good in general, whether they bail you out of coronavirus or not. And so what I recommend to people in this pandemic is, because it's a hard time, people are spending a lot of time indoors, people are often, their routines are really messed up, is, try to eat as healthy as you can, try to get as much exercise as you can. And exercise can come in all forms, so just be active. Right. I don't have any evidence that any specific supplementation is at all useful. So I don't recommend anything. I think if you have a well-balanced diet and you're pretty physically active, you're probably doing everything you can. And obviously the stuff to avoid the infection, avoid large crowds, avoid indoor gatherings, wash your hands, wear the mask. Those are probably the most important things. Clearly much more important than are you eating a specific supplement or diet per se. But staying healthy is clearly an important part of all this.
Okay. What's your stance on the latest goggle wearing, eye protective gear wearing suggestion by Dr. Fauci?
Yeah. So the evidence here is evolving. And I think what we do know is that the key here is something called the ACE2 receptor. This is a receptor on a lot of cells. And this is the receptor that the SARS-CoV-2 virus, the one that causes COVID-19, binds to and infects. And we have a lot of those receptors in our nose, in our throat, in our lungs. But it seems like we also have them in the conjunctiva of our eyes. And so there is more and more evidence that people can get infected through their eyes. And that's been one of the reasons that people have been pushing for face masks and saying, and certainly I see among clinicians, doctors and nurses in the hospital, more and more people wearing face masks. And I think that's clearly appropriate. Whether general public needs to be wearing a face mask, I'm sorry, not face mask. I face shield or eye coverage. Obviously, face mask, absolutely. But things that go over their eyes. That to me probably, again, I just haven't quite seen the compelling data. For general public, I'll tell you what I do. I wear a mask every time I leave my house. But other than that, I don't have any eye coverings per se. I guess I wear glasses, but that's not really protective.
Right. So what's your thought on children wearing masks? I know there's a big controversy that they should go back to school, not to school, in hotspots, yes, no, and it's an ongoing debate, right? But children wearing a mask for 8 hours a day, any problem with that in your eyes?
So for children wearing masks, it's not a problem. There's no health issues associated with it. It's a problem in the sense that it can be a little bit of a pain. And you can imagine young kids struggling a little bit. I have my youngest is 8, and we've gone on hikes where he's worn it for 3-4 hours. After 3-4 hours, he complains about it a little bit, but he can do it. And it's not like he's got some incredible self-constraint. He's a pretty typical 8-year-old who is pretty rambunctious. But so I think most kids can probably do it. No doubt about it. It'll be good for people to get outside, take off the mask, take a break from that if it's bothering them. But I think most kids can probably do it. Most adults can do it. And so I think mask wearing is going to be a really critical part. If we're going to have a shot at getting kids back in school and keeping schools open for the fall, mask wearing is going to be pretty critical. If kids, especially older kids, younger kids a little bit different, the data is a little different, but older kids, if they're not wearing masks, and if the adults are not wearing masks, it's going to be nearly impossible to keep schools open.
Right. There's a lot of data out there suggesting the infectious stage. What is the infectious stage? So if you go into any kind of event where there's a gathering, they'll take your temperature. And my thought is, all right, if they're taking my temperature and I'm asymptomatic, does that really do any good? How long am I infectious? Is it 2 to 14 days? Is it longer? Thoughts, please.
Yeah, we're still learning a lot. There's some new data emerging on this, but let me give you my kind of bottom line assessment. I think temperature checks are largely theater. They don't really do much. Lots of places do it. I don't get bent out of shape. If you want to do it, you can do it. Do I have any evidence that's going to make a difference? Not really. So I'm not, to me, it's not a major intervention. It's probably not harmful. It's probably fine. It's only harmful if you then think that you've done something really useful and don't take other precautions. Okay. How long people are infectious is, we're still learning. My best assessment of all of the research is that people are most infectious sort of in a couple of days before they develop symptoms. And then out to about 4 or 5 days after they develop symptoms. Those are the most infectious period. Most people after about 9-10 days of having symptoms pretty much are not infectious anymore. Most. There are occasionally, there have been large studies where the occasional person is still infectious out to 14 days, but those are pretty rare. And so if the way to think about it, here's a way to think about timeline. Let's say I am exposed today. What will happen is tomorrow I'll feel fine, I won't be infectious. 2 days from now, I'll feel fine, I won't be infectious. This is the average. Obviously, there are variations. Day 3, day 4, people's tests start turning positive. And around day 4 is when they start really becoming infectious and they can start spreading it. And day 5 to 6 is when they start developing symptoms. And for the next 5 days after that, they're spreading the virus pretty substantially. But if you say what's the highest period of spread is 1 to 2 days before they develop symptoms and the first few days after they develop symptoms. And so that's kind of the kind of mental model people should have. So if I got exposed today, I'm fine today. I can't spread it to anybody else. It'll take a couple of days before I even have enough virus that I could even theoretically be infectious, but probably more like 4 days.
Interesting. So for children going back to school in hot zones, are you for it at this point being a father, or do you say they wait to see more data?
No, I think the data on this is getting reasonably clear in my mind. There are areas that we don't know, but so here's the way I think about schools. Schools are super important for kids. Like the benefit of schools is massive. They're also super important for parents. Right. And we want to figure out how to get kids back to schools. Hot zones, about half of the country has a level of community transmission that if we open up schools, in my mind, it's not about being for it or against it. It's just saying, if we open schools, what is the likely scenario? And in my mind, there's very clear evidence that if we open up schools, let's say in Miami-Dade today, or in Houston, Texas, the schools will close within a month. And they will close because you'll see large outbreaks. Mm-hmm. And when you start seeing large outbreaks in schools, you're not going to be able to keep schools open, right? Like parents aren't going to send their kids if half the class has gotten infected, or if 3/4 of the teachers have gotten infected. Like that's just not realistic to keep schools open. So, and here's the point I make to people who are really being very cavalier about this. I say, if you open up in a hot zone, you will get shut down. And then when you get shut down, it'll be nearly impossible to open that school again because everybody is going to be incredibly anxious about opening up again. And so what you're doing, if you're going to be irresponsible, is you could open schools in mid-August, you'll be closed by mid-September, and then you probably can't open up again until like spring. And so don't be irresponsible. So what do I mean? What I mean is in areas that are not hot zones, they should open schools, especially for younger kids, but ideally for all kids. There's a lot of work that needs to go into opening schools. And in hot zones, you just have to decide, do you want schools or do you not want schools? If you want schools, you got to bring the level of virus down. And so I wrote about this, that if in Dallas, Texas, because I have some family in Dallas, if they really wanted to open schools in Dallas and keep them open, like again, you can open up anytime you want, but if you want to keep it open, they got to get rid of bars. They shut down bars. Now they've done that. They should have no indoor dining, no gyms. They've got to do a whole bunch of aggressive stuff to bring the virus down. And then maybe by early October, late September, virus levels will come down enough that you can open up schools safely. But if you don't want to do all of that, then fine. Then you're just saying no schools this fall.
How do you feel about airline travel? Even though you've got a seat next to you, maybe there's one person, empty seat, and another person, it's recirculating air, so forth and so on. Thoughts?
Yeah, so I'll tell you, in the last 2 years before 2020, I flew about 250,000 miles a year. So I fly a lot. And since March, I have not gotten on an airplane. And I am not sure that I would get on an airplane right now. And I'm not somebody who's afraid of airplanes, right? I've literally was flying 250,000 miles a year. So I don't, and here's why. So it's not even so much the airplanes. The airplanes, there is some reasons, there's some debate, and some people think actually it's pretty safe, but there have been some outbreaks. It's everything but, like, if you think about it, it's potentially crowds at the airport. It's the jetway. The jetway makes me terrified from a virus point of view. Because if you think about, if you've ever stood in a jetway, it's enclosed space. It's not like there's good ventilation in the jetway. And if there are people who are infected breathing out virus, it's getting trapped in there and everybody's going to get infected. So I have not flown, and I don't plan to fly until either America stops being kind of the hotspot of the world and we get much, much lower levels of virus in our country, or we have a vaccine. And that pains me because I love traveling. My work has always really, counted on it. And, I was doing 2 to 3 international trips a month. I was doing 5 to 6 domestic trips a month. Like, I flew all the time. But I'm not going to fly at this moment when I don't feel like it's safe to do so.
Right. Well, this has been fascinating. I love all of your comments. I really believe in what you're saying. I'm following you on all of social media platforms, and I can't thank you enough for being on Mentors and Moguls podcast. And we'll check in with you in a couple of months, and hopefully we'll have some better news.
That sounds great. I'd be happy to come back. Thanks for having me.
So much.
That's all for this week. Thank you for listening to the Mentors and Moguls podcast. If you enjoyed this episode, please take a minute to rate and review the Mentors and Moguls podcast wherever you listen to podcasts. You can find bonus video episodes at mentorsandmogulspodcast.com or check out our events page and our blog at heatherrstone.com. Until next time, make it a great day.